I'll be answering with past questions, or I will say practice questions 1B. And the question goes like this. This is a picture of a child with staphylococcal scalded skin syndrome. Question A. What is another name for the condition? B. What is the pathophysiology? C. What are the histological findings? D. List 3 differential diagnoses. Number E. Is there any oral involvement? So this is the same questions I typed for clarity. So the answer to question A, staphylococcal scalded skin syndrome, is also known as Ritter's disease or Ritter's von Richardson's disease in newborn. It is named after Gottfried Ritter, who published a case series of about 300 patients with staphylococcal scalded skin syndrome in the 1800s. The big question is, what is the pathophysiology? The pathophysiology of staphylococcal scalded skin syndrome is actually complex and involves a number of factors that contribute to the development of the disease. It is estimated that about 2 to 5% of Staphylococcus aureus strains produce exfoliative toxins. And these toxins are a class of serine protease exotoxins that are of 2 major types, the exotoxin A and the exotoxin B. There are other isoforms, the exotoxin C and D, which have been observed in other animal models. The exotoxins are also referred to as epidermolytic toxins or epidermolysins or exfoliatins. The toxins are heat stable and resistant to proteases and acidic pH, allowing them to survive a harsh environment and cause damage to the skin. They are encoded by genes carried on Staph aureus, bacteriophage, and plasmid respectively, and they can interfere into the bacterial chromosome and transfer the genes between the bacteria. The toxins is released following expression of the genes locally by Staph aureus and travels hematogeneously and concentrate at the stratum granulosum layer. These toxins are produced during the post-exponential phase of bacterial growth and amine as an inactive precursor molecules. The toxins are activated by proteolytic cleavage by Staph aureus proteases, the aureolysine and staphylococcus A. Once activated, these toxins bind and cleave to desmoglein 1, which constitutes the cytoskeletal protein of the skin in the epidermis. The cleavage of the desmoglein 1 thus leads to detachment of the epidermis, resulting in the characteristic glycerin seen in staphylococcal scalded skin syndrome. The mucosa is not involved in staphylococcal scalded skin syndrome. Some literatures have said that it is never involved. So, the severity of this condition is influenced by various factors, including the amount of the exotoxins produced, the patient's immune response, and the age of the patient. Infants and young children are more susceptible, the under 5s generally, due to their immature immune system, the immaturity of the renal clearance system, and immunocompromised individuals are also at increased risk. Patients with advanced HIV infection, those on chemotherapy, cancer patients, and those on immunosuppressives CKD patients are also at increased risk because of, from central line infection and their compromised immune response. So the C part of the questions says, what are the histological findings? It has been found that all forms of staphylococcal scalded skin syndrome are characterized by intraepidermal subcorneal cleavage or splitting that occurs beneath and within the stratum granulosum. The cleavage space may contain free-floating or partially attached acantholytic cells. The remainder of the epidermis appears unremarkable, and the dermis contains no inflammatory cells or bacteria. So this is the histology of skin in a patient with staphylococcal scalded skin syndrome. You can see the intraepidermal cleavage in the epidermis with separation of the layer. And you can see there's no pointer, cells, acantholytic cells within the cleavage. And then under, there are no inflammatory cells or bacteria. This may differentiate it from other forms of blistering skin diseases, which I will go through later. The three differential diagnoses include the bullous impetigo, the toxic epidermal necrolysis, and pemphigus vulgaris. Bullous impetigo is a blistering skin disease caused by exfoliative toxin. However, the exfoliative toxin are restricted to the site of the infection, and bacteria can be cultured from that blister or contents. It's actually been referred to as a localized form of staphylococcal scalded skin syndrome. Remember, in staphylococcal scalded skin syndrome, culture of the bullous material are sterile. In toxic epidermal necrolysis, 10 causes necrosis of the full Sorry for the interruption.
Hello? Yeah.
Yeah. Okay, so I was talking about pemphigus vulgaris, which is a rare and potentially life-threatening blistering disease, more common in Ashkenazi Jews and people from Indian subcontinent. It usually starts at adult midlife, and the pathogenic IgG antibodies against desmoglein 1 and 3, leading to superficial blisters in the skin and mucosa, are found. So I will talk about other differentials subsequently. I'm going to, then the E part of the question asks about, is there any oral involvement? So as I mentioned earlier, mucous membranes are not involved in staphylococcal scalded skin syndrome. So this is, I'm going to talk about staphylococcal scalded skin syndrome briefly based on the following outline. I would like to just talk about the anatomy of the skin briefly. As you can see, this is the anatomy of the skin with the epidermis, which is on top, which is a stratified squamous epithelium of ectodermal origin. It varies in thickness according to the body site. The thickness is about 0.05 to 1.5 millimeter, and it provides essential barrier against the environment and pathogens. The epidermis is mainly composed of keratinocytes and In the basal layer, the keratinocytes synthesize a variety of keratin filaments and chromosomal proteins, the desmoglins and the desmoplakinins, which make up the cytoskeleton and gives the cell tensile strength and cohesion. Higher off in the granular layer, the lipid and lipid hydrolysis are found. So, by way of introduction, staphylococcal scalded skin syndrome is also known as Ritter's disease, named after Gottfried Ritter. It's a rare but severe skin condition caused by exfoliative toxins produced by the bacterium Staphylococcus aureus. It's a syndrome of acute exfoliation of the skin, and severity varies from blisters to severe exfoliation affecting almost the entire body. It is most common in children and neonates, but rarer in adults. It has been described in adults with renal impairment, immunologic deficiency, and other chronic illnesses. Overall incidence is high in developing countries, and wherever the incidence of staphylococcal infection is higher. And it's more common in warm climates, and it's more frequently reported during the summer months. The mean annual incidence can be approximated to 7.67 per million US children, with 45.1 cases per million US infants aged less than 2 years. The pathophysiology is complex, as I have already talked about this when I was answering the B part of the question, so I think there's no need to go through again. So clinical presentation, staphylococcal scalded skin syndrome presents as a macular erythema followed by diffuse epidermal exfoliation. A prodromal localized staph aureus infection of skin occurs. Infection often is not apparent before the rashes appear. Patients may present with general malaise, fever, irritability, and on physical examination, there may be tenderness to palpation in the skin. Patients may be febrile with generalized or localized erythema. They may have conjunctivitis. There may be peroral crusting with sparing of the mucous membranes. Patients may be dehydrated with a positive Mikulk's sign. Positive Mikulk's sign is like extension of the bulle or appearance of the bulle with gentle pressure in the skin on the affected site. Diffuse erythematous rash often begins centrally, and the bullae are flaccid and ill-defined. Exfoliation of rash, which may be patchy or sheet-like in nature, is noted. This is a patient with staphylococcal scalded skin syndrome. You can see the widespread erythematous rashes on the arm, the trunk, and the face. These are some bullae in the skin of patient with staphylococcal scalded skin syndrome. You can see they look raw when they rupture, and they can appear anywhere in the body. This is another patient. You can see the perioral crusting and also some lesions around the eyes, but there is no involvement of the oral mucosa. The differential diagnosis I mentioned earlier, villus impetigo, toxic epidermal necrolysis, pemphigus vulgaris, pemphigus foliaceus, which is actually a rarer variant of pemphigus vulgaris, in which the target antigen is desmoglin 1. Direct immunofluorescence of ferrolegional skin demonstrates intracellular IgG deposition. Circulating intraepidermal antibodies are also detected in pemphigus foliaceus. Another differential is the bullous pemphigoid, which usually affect those over the age of 60 years, and autoantibodies against 230 and 180 kilodalton hemidesmosomal protein plays a pathogenic role. It causes subepidermal blisters as against the intraepidermal blistering seen in staphylococcal scalded skin syndrome. Another differential is linear IgA disease, which is a rare subepidermal blistering disorder. And pathogenic IgA antibodies are bound to several basement membrane proteins. Dermatitis herpetiformis is another differential, which is an autoimmune subepidermal blistering disorder that is often associated with the gluten-sensitive enteropathy. It's considered a cutaneous variant of celiac disease, and it's an exclusively pruritic eruption classically seen in the buttocks and extensor surfaces of the arms and legs. Another differential is subcorneal pustulosis, which is also known as subcorneal pustular dermatosis, rare chronic relapsing pustular eruption. And the classical lesion has this half and half blister with a purulent fluid in the lower half of the blister and a clear fluid in the upper part. So investigations include full blood count and differentials, which may show neutrophilic leukocytosis. ESR may be elevated. PCR serum test, where available, can be done, also helps in making the diagnosis. ECR is also important. Some patients may present with complication of AKI and electrolyte disturbances.
So Dr. Shams, did you try a round up so that we can discuss?
Yes, sir. Blood culture is also important, but remember the gram stain or culture from the remote infection site is negative. Sorry, it can also be found in the remote site of the infection, but not the distant bully. The management is multidisciplinary, including a pediatrician. It involves a pediatrician, dermatologist, infectious disease specialist, plastic surgeon sometimes could be needed. It consists of supportive care and eradication of the primary infection. Intravenous fluids for rehydration, very important, in form of normal saline or Ringer's lactate in patients with electrolyte disturbances. And then parenteral antibiotics with prompt treatment with parenteral anti-staphylococcal antibiotics is essential. Most staphylococcal infection implicated in staphylococcal scalded skin syndrome have penicillinaceae and are resistant to penicillins. Penicillinase-resistant synthetic penicillins such as napsilin or oxacillin should be started promptly. In areas of significant MRSA prevalence, or if MRSA is suspected, antibiotics with MRSA coverage, e.g. vancomycin or linezolid, are indicated. Clindamycin may also be used to inhibit bacterial liposomal production of exfoliative toxins. Fresh frozen plasma, 10 mils per kg, could be given to affected children. It has been observed that more than 90% of affected adults over the age of 40 years have antibodies to exfoliative toxins. Therefore, children with staphylococcal scalded skin syndrome may receive a dose of fresh frozen plasma 10 ml per kg to neutralize the exotoxins. Topical wound care using molnupiravir is also important, and all the necessary care given to burn patients because the skin is exposed to the environment and have lost its hemostatic function. Patients with severe disease may require ICU or burn care unit care. Steroids are not indicated and may worsen the immune function. And non-steroidal anti-inflammatory drugs and other agents that potentially affect renal function should always be avoided. Prevention of staphylococcal scalded skin syndrome could be done by adhering to good hygiene practices, which include proper and frequent hand hygiene. Avoid sharing items such as towels and clothes. Keeping fingernails short and clean, using clean and dry beddings and clothing. Keeping wound and cuts clean and covered. And prevention of contact of infected individuals in child care centers and schools. Complications include severe dehydration, shock, acute kidney injury, hypothermia, sepsis, scarring and disability, and if not properly managed, patients will die. Prognosis of staphylococcal scalded skin syndrome in children is excellent, with less than 5% mortality.
All right, Dr. Shamsuddin.
In 10 days, yes,
thank
sir.
you. Dr.
Unfortunately,
Shamsuddin, thank you.
Is over 50%. Thank you very much for listening.
Yeah.
These are my references.
All right, thank you very much, Dr. Shamsuddin, for an excellent presentation. So the class is open for contributions, comments, questions. You can type in the chat box or you can raise your hand electronically. Any questions, any clarifications, any contributions? In the chat box there, thank you for an excellent presentation. Any other contributions, any other? Dr. Itoha is saying, can you go through histological findings again?
Okay. Okay, I mentioned that all forms of staphylococcal scalded skin syndrome are characterized by intraepidermal subcorneal cleavage with splitting that occurs beneath and within the stratum granulosum. The cleavage space may contain free floating or partially attached acantholytic cells. And the remainder of the epidermis appears unremarkable. And remember that the dermis contains no inflammatory cells or bacteria in staphylococcal scalded skin syndrome. This is how the histology appears. Thank you.
Okay, Dr. Abdullahi.
Okay. Thank you, Dr. Shamsu, for the excellent.
Make your comment.
Okay, thank you, sir. Thank you, Dr. Shamsu, for the excellent presentation. Just
Thank you very much.
The management, you should remember to give the tetanus prophylaxis, tetanus toxoid, and anti-tetanus serums are also important, as some of them they may stay long on admission with the breach of skin one of the complications is tetanus, so we should remember to give them the prophylaxis. Thank you very much, sir.
Thank you. Yeah, that could be
Thank you.
important in deep wounds, actually.
Okay. Yeah, thank you. Let me go to the chat box. Okay, Eunice is saying, I joined late. Is the patient pediatric age? Is the patient of pediatric age group? Did you mention the age, Dr. Shamsuddin? Okay.
Yes, I did. Mostly it affects.
No, from the question. From the question.
Okay. No. There was no question that
Age.
asked about the age group of the patient.
Yeah,
Let me go
you
back.
mentioned that it's mainly in the pediatric age group from your
Exactly.
presentation.
The under 5.
Yeah.
This is clear.
Thank you. And then Dr. Jamila is saying, can you clarify that? That's it. What's it about biopsy sites from a remote site? It wasn't really clear. The biopsy sites. Did you mention? Yeah.
Well, the biopsy could be taken from anywhere, not necessarily the remote site, and it shows the typical features. Yes, I described.
Yeah, so there are no specific sites for it.
Yes, there is no. Because sometimes you cannot find the remote site. It's only when the bully have appeared that you see the characteristic findings seen in staphylococcal scalded skin syndrome.
Okay, Dr. Chinwe is saying, is there any place for barrier or reverse barrier nursing?
Yeah, very important. Some of these patients may need care typical of burn patients because of the extensive nature of the skin lesion. It could be really extensive, involving the entire body.
Yeah, so Dr. Success is saying, please, what are your principles of management?
The principles of management I mentioned, you have to give antibiotics, you give rehydration, then the topical skin care and other general nursing care given to the patients.
Okay. So Linda is saying, okay, age range includes newness to less than 6 years. Dr. Ekele said, can we use a petroleum jelly as part of the management, as part of the support management?
Yes, it could be used together with mupirocin cream I mentioned. Petroleum jelly has to be, yes.
Okay, is there any other question? Yes, ma.
I must appreciate the presenter, Dr. Shamsuddin. It was a wonderful presentation coming from a non-dermatologist. It's a wonderful presentation coming from a non-dermatologist. However, just for the purpose of this class, I wasn't so satisfied with the principle of management, the way you went about it. I wasn't so satisfied. We have a lot of dermatologists here. Dr. Jamila, Dr. Ito, and Dr. Jamila, you both should be contributing, not giving questions. You should be contributing if I dermatologist here. So please, can any of you just highlight the principles of management? I know somebody and the role petroleum jelly has. Dr. Jamila. also my people have denied me. Also, I saw her.
Good morning. Good morning.
Good morning.
And colleagues. Okay, so for this patient in particular, which tends to appear more like burns patient, so we want to have barrier nursing care for them. That would help reduce water loss as much as possible. Then also, in reducing water loss, you want to moisturize the skin. And in moisturizing the skin, we use more of petrolatum containing ointments. It could be petroleum jelly. It could also be liquid paraffin. That would help. It helps to lubricate the skin and retain fluid moisture within the skin, preventing water loss as well. Then other nursing skincare that is required, apart from taking skin swab for MCS, we use 2% mupirocin ointment as well to take care of the Staphylococcus aureus that is implicated in this particular patient now. Then, of course, apart from this, we also consider what they use for beating, all to moisturize the skin. So we could ask that liquids like glycerin oil be included into the bath water. That would also help to moisturize the skin. And soaps that are very close to the skin pH, like Dove, can also be requested to be used in such patients while bathing, at least. That's for the nursing care, essentially skincare we want to carry out on this patient. Then other management, like you earlier mentioned, you want to hydrate them. You give them intravenous fluids to keep them well hydrated. Intravenous antibiotics, like you mentioned, to treat the underlying infections. And of course, other management to prevent complications. We've talked about the ETS and the tetanus toxoid injections. I think, I don't know if I didn't cover anything. Maybe I could be helped from here. Thank you.
Thank you, Dr. Itoa. Thank you. That was wonderful. Thank you so much. I know I put you on the spot. I want more of our participants to be speaking, not just the facilitators only. You guys are specialists already, so you have to stop. So just to add, such persons will encourage reverse barrier nursing. If I reverse, I'm both reverse and barrier nursing. All you want just to minimize. Reverse barrier nursing is what is reverse barrier nursing? Barrier nursing is when you are protecting yourself. The reverse barrier nursing, the patient is protected from infection. Just the way we do patients that have Lassa, you see all that. The infection from getting the infection from the patient. That's barrier nursing. Why reverse barrier nursing? Because they've lost a lot of skin, you want to, the skin is also a part of protective barrier, protect the body from infection, entrance, and other external factors. So now they don't have that protection anymore. So you are protecting them from the environmental factors and from other sources of infection from those within them. Such persons, you minimize touching them. Don't touch them except it is necessary. You sterilize your hand properly, wash properly, sterilize properly before you touch them. Then I think that's on reverse nursing and reverse barrier nursing. Then the feeding, such patients, you should weigh them daily. such patients, hope I can be heard clearly. Such
Yes.
patients should be weighed daily. You want to weigh them, especially the skin loss, the skin that was lost during the day. I mentioned this before. You weigh it daily to give an idea of the amount of keratin, amount of skin they are losing daily. Because we want to talk about diet. Diet is important. You want to do high protein diet, actually animal based. For children, eggs, fish, more of animal based than plant based form of protein. So the idea of weighing their scale is their skin loss is to know if they haven't responding at all to treatment, and also to give an idea of the protein you need to supplement, because keratin is in the skin and keratin is a form of protein. So once they're losing a lot, you have to go beyond that gram in replacing, supplementing. So that's the importance of weighing the patient's the skin loss. So you tell the caregivers they are shedding the skin, they should just keep them aside. The dermatologist will always come and weigh them and use the information for other management of the patient. I think all other things have been mentioned already, so let's not drag the issue. So thank you so much, Dr. Itoa. Thank you, Dr. Yusuf. That was wonderful. Well done.
Thank you, ma'am.
Right. There are some questions also. Okay. Chief has differentiated. I hope Anthony heard, because he asked for difference between barrier nursing and reverse barrier nursing. Dr. Ekele was saying, what is the fresh frozen plasma for? Dr. Sok says, as serious indicated, he mentioned they are not indicated. Severe ichthyosis, can it also be a differential? Linda is saying eradication of primary infection with rehydration topical wound care. I think she's highlighting the principles of management. Dr. Anthony is saying, is the management multidisciplinary? Yeah, he mentioned that also. And then Blessing is still asking the same question asked earlier by Ekele. Clarify the role of fresh frozen plasma in Ritter's disease.
Yes.
And then Dr. Jennifer, sorry, let me take the last one. Dr. Jennifer is saying the term reverse barrier nursing has been superseded by double barrier nursing. So, all right, so you can go ahead.
Yes, as I mentioned earlier, it has been observed that more than 90% of adults over the age of 40 years have antibodies to the exotoxins. Therefore, children with staphylococcal scalded skin syndrome may receive a dose of fresh frozen plasma to neutralize the exotoxins. It's just to neutralize the exotoxins. That's the purpose. Thank you.
Okay, thank you for the response. Any other comments or any other contributions?
I think we should move over to the next question.
Change this, remove this key. Everything start, change the battery of the key. Everything start working well.
Okay, so in the absence of any question or contribution, any other person with his or her presentation ready to present?